Hello, everyone, and welcome to the TMA's Ask the Expert podcast series. Today's podcast is entitled A Conversation with the Transverse Myelitis Association James T. Lubin Fellows. My name is Sam Hughes, and I'll be moderating this podcast today. The TMA is a nonprofit focused on support, education, and research of rare neuroimmune disorders. You can learn more about us on the website at myelitis.org. This podcast is being recorded and will be made available on the TMA website for download via iTunes. During the call, if you have any additional questions, you can send a message through the chat option available with GoToWebinar. For today's podcast, we are very pleased to be joined by Dr. Cynthia Wang and Dr. Olwyn Murphy. Dr. Cynthia Wang received her medical degree from the University of Texas Southwestern Medical Center in Dallas, Texas, and completed a pediatrics and pediatric neurology residency at Mott Children's Hospital at the University of Michigan Health Science System in Ann Arbor, Michigan. Dr. Wang is currently a James T. Lubin Fellow under the mentorship of Dr. Benjamin Greenberg at UT Southwestern and Children's Health. Her research study is a prospective longitudinal study on acute disseminated encephalomyelitis, or ADEM, to identify the clinical characteristics, treatment methods, and follow-up interventions that are associated with patient outcomes. Dr. Olwyn Murphy received her medical degree from University College Dublin in Dublin, Ireland, and completed a neurology residency at the Royal College of Physicians in Ireland. She is also a James T. Lubin Fellow at the Johns Hopkins Transverse Myelitis Center in Baltimore, Maryland, under the mentorship of Dr. Carlos Pardo Villamizar. Dr. Murphy's research is on predicting outcomes after a diagnosis of a transverse myelitis using current imaging techniques and spinal fluid analysis. The goal of her research project is to identify patterns or biomarkers that can be used in day-to-day clinical practice to identify benefits from therapies and to help make better decisions about care. Welcome, and thank you both for joining us today. And so, for everyone who's listening, we're going to structure this podcast where about the first half or so, we're going to turn it over to Drs. Wang and Murphy to kind of give an overview of their fellowship, what they've learned, what they've done, how it's impacted them, and to talk more about the research that they're doing and want to continue to do. And then in the second half or so, there are a few specific medical questions from the community that we can ask and maybe get some answers from Dr. Wang and Dr. Murphy. So we'll go ahead and start, and I'm going to turn it over first to Dr. Murphy to discuss her fellowship and what her research is. Dr. Murphy?
Thanks, Sam. Well, I'm working in the Johns Hopkins Transverse Myelitis Center, primarily with Dr. Carlos Pardo, who's an expert in myelopathies and transverse myelitis. And I'm able to be there thanks to the TM Association and the support of the James T. Lubin Fellowship. I started with Carlos Pardo in Johns Hopkins last summer, so just a year ago now. So I'm heading into my second year of fellowship now. And we've got quite a few interesting research projects going on that I think the TM community would be interested to hear a little bit more about. The main focus of our research is on improving the diagnosis of patients with myelopathies and trying to predict the prognosis and outcome for patients. One of the issues that people in this community and our patients encounter is that transverse myelitis is quite a non-specific diagnosis. It's kind of a basket term used for patients who experience a range of different types of disorders of the spinal cord. And what we're trying to do in the Johns Hopkins Transverse Myelitis Center is to define the diagnosis more clearly for these patients and establish better routes of treatment and rehabilitation for patients with myelopathies or spinal cord disorders. I'm particularly focused on differentiating the types of myelopathies in adult patients, as opposed to Cynthia, who works quite a bit with pediatric population in UT Southwestern. So one of our projects that I might talk a little bit about focuses on issues with vascular compromise or problems with the blood supply to the spinal cord. imagine that you're diagnosed with transverse myelitis and told that it's due to inflammation. You might receive some treatment, but however, you keep getting worse. And then maybe eventually, after finding 5 or 6 doctors, different specialists, maybe 1 or 2 years have passed and you keep getting worse, you might find out that the diagnosis you were given in the first place wasn't actually accurate. And in fact, the problem with your spinal cord was more a problem with the vascular supply and something that could be treated with surgery. This is unfortunately a relatively common clinical scenario that we encounter with patients at the TM clinic. So to try and analyze this situation further, we've looked at 100 cases of people with vascular malformations of the spinal cord in order to try and better understand these kind of disorders and improve the diagnosis for patients who have this type of myelopathy. We have found out that most of these patients with vascular malformations were told that they had inflammation and were actually treated with steroids, which made their condition worse in some cases. This also led to a delay in diagnosis of the correct disorder, which on average it took 17 months for patients to be diagnosed accurately and resulted in a delay in the correct type of treatment. So fortunately, through our research, we have been able to identify some clues to this diagnosis. For example, being an older man with a particular pattern of symptoms occurring with exercise and with particular findings on the neurological exam. So for us, raising awareness of these clues to the diagnosis by presenting our research to other neurologists and publishing our findings will help neurologists identify this condition and improve the likelihood that patients who suffer myelopathies and spinal cord disorders will get the correct diagnosis and treatment. What we're now looking at to bring this research forward is the MRI scan in these kind of patients. So any of our listeners who have experienced an episode of myelitis or myelopathy will know that the doctors place great importance in the MRI scan in diagnosing the condition and perhaps trying to predict the outcome. So in our case, we've been able to differentiate some features on the MRI scan, which can help us in giving a more accurate diagnosis to patients with myelopathy, such as the location of the lesion in the spinal cord, whether it occurs in the upper part or the lower part, and then in a cross-sectional view, whether it occurs in the center of the spinal cord or the more peripheral areas. We hope that bringing this research further will help us try and predict what types of outcomes patients can expect and therefore guide the rehabilitation project further. So that's kind of a summary of one project we are working on. Another thing I can talk to our listeners about is a second project where we're looking at patients who suffer from spinal cord strokes. Again, this is a condition that's commonly thrown in the basket of myelitis, or patients are given a diagnosis of transverse myelitis or myelopathy, when actually a more specific diagnosis of a stroke in the spinal cord is more accurate. So we're again working on features that we can use to differentiate these kind of patients and trying to find which patients are suffering from a spinal cord stroke and which patients are actually having inflammation in the spinal cord. And we've identified that risk factors for cardiovascular disease, such as high blood pressure or high cholesterol, are more common in patients with spinal cord strokes as compared to patients with inflammatory lesions of the spinal cord. And furthermore, clinical features like a very rapid onset of the clinical syndrome with associated back pain may also help discriminate between these two spinal cord conditions. So that kind of gives a flavor of the type of projects that we're working on. My plan for my second year here is to stay focused on these research projects while also spending time in the clinic working with people with transverse myelitis and other types of myelopathies. And this ongoing support from the Transverse Myelitis Association helps us move this research forward.
That's great. Thank you very much, Dr. Murphy. I think your work focusing on kind of the differential diagnoses between TM and these vascular disorders can be very helpful and is something that I think is talked about a lot, but not too much actual rigorous research is going into really categorizing, the clinical features of the different types and the imaging features. So I think that could really go far in the future. So I'll throw it over to Dr. Wang now, and she can kind of do the same and discuss what her fellowship has been like and what kind of work she's been doing. And then after that, there are a few questions that I can ask you guys about your history and your training. Dr. Wang?
Great. Thanks a lot, Sam, for that very kind introduction, and thanks again to the TMA for this opportunity to talk on the podcast and for supporting my fellowship. While I was listening to Dr. Murphy, there was certainly a lot of parallels between our research projects. Mine in particular is focused on acute disseminated encephalomyelitis, or ADEM, and my fellowship project has been really doing tackling some of the same questions, asking, what are the clinical characteristics, initial studies we get, how do these determine long-term outcomes in ADEM? Similarly to transverse myelitis, a lot of different conditions likely get diagnosed with ADEM that we find out become other things such as multiple sclerosis or NMOSD. So part of my project is exploring what can we do from kind of the earliest time point to help diagnose the condition correctly, and then what type of follow-up is necessary to best serve the patients. Part of this, through my project, we've discovered there's certainly a subset of patients who definitely have the presentation that looks like ADEM, having what we call encephalopathy or some clouding of their awareness level and multiple lesions in their brain, but they are a more specific subset in that they all share an antibody called to myelin oligodendrocyte glycoprotein, or MOG. And I know recently there was a podcast on MOG, which I recommend anybody with interest in that check it out. But essentially we're finding that MOG behaves slightly differently in that these children and typically young adults who have this antibody and persistently have this antibody may go on to have further attacks. For long-term, and the way I've learned it in medical school was that ADEM was a monophasic or a one-time event, and we're learning for the population of MOG-positive patients that may not be true. The other part is also exploring what the long-term outcomes of ADEM are, and really trying to ask the right questions and being able to anticipate sort of the deficits that may unfold over time. I worked with Dr. Lana Harder, who's a neuropsychologist, and she has a term which I really like, which is children growing into their deficits with ADEM, meaning that at a young age in which ADEM may strike, such as, as early as 4, 5, 6, a child's the demands that we expect in terms of level of understanding, academic achievement is often at a lower bar than say when they're in older elementary school, middle school, and high school. So I think one question that hasn't been adequately answered by neurologists and people who work with this population is, are there deficits that can be unmasked over time? And one thing that we want to do with our project is to look at these children and young adults longitudinally over multiple time points to see if deficits get better, or if there's some deficits that may be more readily apparent over time. And I think based on some of the existing literature, there certainly are deficits which may be subtle and in specific domains, such as in processing speed, visual motor integration, some regulation of behavior, and so forth. We hope to have all participants in our study have neuropsychological testing, and I think that will help answer those questions. Let's see, in terms of, I'll pause there if that's a good enough introduction.
I think that's pretty good.
Okay.
Thank you for that, Dr. Wang. I think the work in ADEM is really important. It is, and at least historically, often been, for lack of a better term, neglected in terms of the research and the outcomes. And there's a lot of very old descriptions of it that don't necessarily correspond with a lot of the outcomes that are seen in the clinic, and especially with the advent of the MOG antibody in these patient populations. There's a lot of work that can be done, and so I think it's important that you are focusing on that, especially as a pediatrician as well as a neurologist. So I wanted to dive in just a few questions to kind of flesh things out a little further. I'm always interested in kind of what got you to this point. What made you or what makes people go down one certain route in their life and their career as opposed to others? And so I would just be interested, and hopefully the community is also interested, just to hear from both of you and kind of how you got into neurology. What brought you or attracted you to the world of neurology, and even then, into that subset of these neuroimmune disorders? I think it's always fascinating for me to hear kind of the anecdotes about how that happened. So I'll start with you, Dr. Murphy, again. Could you give us a little bit more about your past and how you found your interest in neurology and neuroimmunology?
Sure. Well, I really found neurology fascinating since the time I was a medical student in Ireland. One of my mentors was a very experienced professor who had a great relationship with his neurology patients over many years. And I remember that he liked to call neurology the last frontier in medicine because there's so much still to be discovered and understood about the brain and the nervous system. That was something that really interested me. And I think as a medical student, when you're choosing which route to go, it depends on what kind of work you want to do as well. I mean, there's the option of doing sort of fast-paced crisis kind of situations, like being an emergency department doctor or a surgeon, or there's people who are more interested in kind of the long game, where you deal with people with maybe chronic diseases or recurrent problems over many years and try and help them over a lifetime. And I think I was always more interested in that kind of medicine. What attracted me particularly to neuroimmunology was actually a couple of patients that I dealt with during my neurology training. I remember seeing a young man with transverse myelitis. He was only about 20 years old, and I could see how frustrating it was for this young man when we were unable to explain to him what exactly had caused his transverse myelitis, and we weren't able to say whether or not this would come back. So this guy was looking at many years ahead of uncertainty. And I remember thinking, wouldn't it be great if we could try and do some more research and try and improve things for people with these kind of disorders and help sort of predict the future. Another case that struck me was a mother of young children who developed an immune-mediated encephalitis. And she had difficulty returning to work and really getting back to her normal life after this due to memory problems. So I think it was seeing those young people being struck out of the blue by these kind of rare disorders that made me want to delve into it further. And I guess I hope that if I work with these kind of patients over my career, I can make a difference in this area and to patients' quality of life.
Yeah, thank you for that. It's always interesting what you say about being that neurology is the final frontier in medicine. I find interesting. My academic background is in neuroscience, and I remember being, just even as an undergrad, being attracted to neuroscience because I would ask questions, and the professors would say, "Well, we don't know the answer. You should go talk to so and so and see what kind of work they're doing." And I felt like, wow, there really is a lot of work to do, and a lot of impact that can be made by anybody who has questions. And feeling like this is the final frontier, or the next frontier. So I think from the I think that that's very interesting. Dr. Wang, would you like to give us a little bit more of your background and your interest in neurology?
Yeah, sure, Sam. I think, neuroimmunology is a really interesting and captivating intersection of many disciplines, and I think that's what really attracted me to it. If I really had to think, I think I could probably trace it back to high school summers when I was working at a immunology lab. They were looking at how the HIV/AIDS virus actually kind of co-opts a person's immune system, and in their particular case, there are some people who are more likely to get worse infections of the virus, and there are even some people who are virtually immune to the virus. So it was definitely triggering a lot of interesting questions in my mind. You know, what is the interaction between an infectious agent, the immune system, and how does that manifest in different people? So I think that was my first maybe entry into this field, but certainly throughout college, I was interested in the neurosciences. I majored in psychology, which provided many different perspectives of kind of the brain and the mind, and I was, you know, equally fascinated with things that was, you know, very basic science about how, you know, neurons electrically work, to things that were higher order, including, you know, how do we process things like vision or emotion and things like that. And then I've always wanted to work with children, so that kind of gave me the pediatric part. And really, it was just, you know, through medical school, learning about these subjects, seeing patients with these conditions. Oftentimes, they'll be, you know, very mysterious to people because these tend to be so rare that there's a lot of diagnostic testing and a lot of, you know, thinking that goes behind making these and treating these conditions. So I think I found all that really fascinating, and it really just kept the doors open and, you know, what I could study. And like Dr. Murphy said, it really is, there's many unanswered questions, and hopefully this will give us, you know, many opportunities to improve the research and the clinical management for these patients.
Yeah, that's great. Yeah, it's interesting how even going back to high school and experiences that we have that, you know, you might not even have necessarily searched out, but you found yourself in the situation, learning this kind of thing kind of forms the rest of your career without even knowing it. So that's very interesting. Another question I wanted to ask you guys before we kind of dive into questions from the community is, you know, on these podcasts and in a lot of educational settings, we talk a lot about the multidisciplinary, the need for multidisciplinary care with these neuroimmune disorders, especially these chronic disorders, and you know, including neuropsychology and PT and even diet and all of this. And it all sounds well and good, but that can be very difficult to include in to find all of these professionals to be able to do all of this as a patient. And so I would wonder what you guys have learned through your training, just from medical school on, and especially in the context of not necessarily being able to find a lot of multidisciplinary care, what advice you have for patients who are working with their physician, with their neurologist, who might be the only real physician they can afford to or can find to help them. What advice would you give patients to get the most out of the appointments that they have with their neurologist, and to foster the relationship with that, with the neurologist? Dr. Murphy, do you have any thoughts on that?
Sure. Well, I think the first thing that's really important when you're going into your appointment with your neurologist is to think about the goal of your visit. For example, if this is the first time you're seeing that specialist, are you looking for a second opinion on your diagnosis or an opinion on your MRI scan? Or else, are you more concerned about your rehab program? Are you looking for guidance on that? Or are you wondering which kind of medications are best for pain management? I think going into the appointment with an idea of what you want to get out of it can help you kind of keep things on track, because sometimes when you go in the door, the conversation can stray to something else, and you can end up coming out of the appointment and realize that the reason that you went there in the first place hasn't actually been addressed. And secondly, I think what's really important is to bring a pen and paper and write down some questions you want to ask the doctor and write down their answers. Because again, the appointment can fly by and you can walk out the door having missed out on some of the important points. I think what you say about the multidisciplinary team is really important, and we're fortunate, I guess, in the transverse myelitis center in Johns Hopkins to have access to some of these specialists. We have expert nurses, and we work with excellent physical therapists and psychologists, and this really, I think, enhances the experience for both patients and for their physicians, and working together as a team, I think, can improve the rehabilitation. But oftentimes, a lot of this actually falls on the patients themselves to be the coordinator of their own care and to be making phone calls and pushing for appointments and things. And I guess I would just encourage people to try and access therapists in their local community and use the Transverse Myelitis Association as a resource to maybe point you in the right direction of different places for rehabilitation, and to keep pushing for your own rehabilitation, because at the end of the day, you may not be able to access a center locally to you that has a full multidisciplinary team in one place.
Yeah, that's very good advice there. Dr. Wang, do you have anything to add, especially from your experience with pediatrics and working with parents of children, in terms of making the most out of their appointments and coordinating care for their child?
Yeah, absolutely. I really think Dr. Murphy made some excellent points. I completely agree that these visits have to be goal-oriented. So you should come in with major issues and questions and concerns, and that will lead the provider to really address those. And then hopefully they will also give you some task or something that they should, or something that the patient should report back to the doctor, so that he can continue to improve and not leave things as status quo. I would say for pediatrics, there's certainly a different dynamic. The child may not be aware of their condition, but I think when they get to an age where they're older and able to understand that they should be a part of the conversation, especially as they get into teenage years, we make an effort to really transition teenagers so that they take on more and more aspects of being responsible for their care. And I think even a young child can probably express some preferences in terms of sometimes we do different medications of different routes of administration. So taking into context some of those things can really help with daily quality of life issues. If there's an alternative to get an infusion or injection medication versus a pill, or vice versa, sometimes those things can really help with compliance. And then I guess I would just add, in terms of some of the more logistical aspects of the appointment, is that as we're kind of hindered by the amount of time we can spend with patients, it's really helpful if patients can be organized, especially if it's a second opinion, about bringing records in a way that would allow the clinician to really get at the important things in their medical history. Oftentimes I'll have patients bring in a 1 or 2 page synopsis with really the key presentation, hospitalizations, any treatments they received, surgeries, medications, including the doses that they have tried and what led them to either stop it. Was it side effects versus it not being effective? I think that's really important, because many of the concerns may have to do with optimizing symptom management. And then bring any records, particularly MRI discs. Whenever you get an MRI, if you can just ask them for extra copy and you keep that in your possession, and that would be really helpful for anybody trying to give you a second opinion. And then any spinal fluid studies and any testing of antibodies, especially if it's somebody who's had transverse myelitis. Testing for things like aquaporin 4 and MOG, those are often very important, and you can eliminate some redundancy by having somebody retest if you've already had that before and know that you have. So yeah, I think just kind of being prepared, going in knowing what you want from the visit, and if you did not get that, then being open about asking, how should I follow up with these issues so I can get the remainder of my questions and concerns answered.
Mm. That's good. A lot of the feedback that we hear and work that needs to be done from the patient side is really to not be passive in their care. I think a lot of people go into in whatever form of healthcare they're looking at, whether it be chronic care or acute stuff. They go in there and expect to be told what to do. And while there's a certain amount of that, I think especially with these rare disorders that a lot of people don't know a lot about, is being your own advocate, learning as much as you can, like just listening to these podcasts and trying to get more information and working with your provider, your neurologist, and doing the best you can to organize and coordinate your own care, and not be a passive bystander in it. I think we can all take a cue from that in our own lives, in our own healthcare. So thank you both for kind of that overview of your work and your experiences working with patients with neuroimmune disorders. And through the second half of the podcast, there are a few questions that came in from the community that are a little bit more disease-specific or medical questions that I wanted to ask and see if you, either of you can help elucidate some information about them. And I'll start with you, Dr. Wang. I'm going to ask you every pediatrician's favorite question about, is there any kind of a potential connection, or what is the most recent understanding of connections between vaccinations and transverse myelitis or any other of these immune-mediated neurologic disorders? It's a hot topic. It continues to be a hot topic, and I think especially in the pediatric world. So in a few sentences, if you will, can you give us an overview of what is the current thinking behind any connection between vaccinations and immune-mediated disorders?
Sure. Yeah. No. Let's. I'll try to do my best. I think when I come to this topic, I want to be open-minded and I want to hear people out if they really believe that there is a connection, but at the same time, point out some assumptions that may be made that led to an association being interpreted as causation. So in terms of our knowledge of etiology of these rare neuroimmune diseases such as transverse myelitis, we often will kind of give the example of an infection triggering an abnormal immune response. So instead of your body trying to chase away a virus or bacteria, maybe getting confused and recognizing parts of your own body as something foreign and attacking it. So then we have to think about how immunizations work. It's introducing, usually dead or at least, weakened particles of viruses and bacteria, and then letting your immune system go at it and then build a response so that when you meet the, real virus or bacteria in the wild, so to speak, your immune system will be better prepared to, to eliminate and fight it off without you getting clinically sick. So I think there certainly is reason to believe that maybe vaccinations can trigger an abnormal immune response in the right individual. I think that gets at a lot of what we're trying to figure out, which is these diseases don't seem to be caused because you have a specific set of genetics or genes. They don't seem to be caused just if you're exposed to a certain infection. We see examples where hundreds of thousands of people may get the common cold or flu, and they don't get transverse myelitis. So what about the specific person, their genetic makeup, and then that interaction with the environment causes the condition? So I think that is definitely one of the most interesting and notable questions in our field. With that said, from a population standpoint, it definitely makes sense to immunize everybody, just because, actually, when you look at some of the classical descriptions of ADEM, the incidence of getting ADEM after you get an infection like measles or flu or so forth is actually much higher than the immunization. yeah, I think it's hard to argue with a parent who says, you know, they got this immunization and within 48 hours something happened. But I think if there's not as much of a connection, if it happened several weeks out, and if it's in infancy, if you can imagine when a infant comes in, it's like every couple of months there'll be vaccinations. I think in those cases there's a danger in making a causal relationship or thinking there's a causal relationship when there is none. You know, at UT Southwestern, we recommend that everybody gets the normal vaccine schedule. We think having family members get vaccinated if you are just, you know, too concerned about and too nervous about vaccinating your child, or you know, if you're adult, if you're getting it yourself, then at least have people in your family get vaccinated. And I think, I don't know if Chrissy or Gigi want to talk about it, but I heard that there was maybe some studies about vaccines that are going on to the TMA. So I think it's a question that hasn't been fully answered, but in general, I give the advice that you're more protected by getting vaccinated than being exposed to these infections, which are have a higher risk of triggering one of these rare neuroimmune diseases than the vaccination itself.
It's very interesting. Very nice overview. Dr. Murphy, do you have anything to add to that, especially from the adult standpoint?
Well, I guess I was glad that you asked Dr. Wang the question, because it's really interesting but very tricky and challenging question for all of us. I would take maybe a slightly different perspective from an adult point of view. What we frequently get asked in the clinic is not whether a vaccine has triggered an adult's episode of TM, but whether an adult who has had TM should get a vaccine in future. Maybe their TM was from something completely different or an idiopathic, but patients are then wondering if they have had some sort of immune-mediated event in the past, is it safe for them to get a vaccine in future? And generally our advice would be yes, that most routine vaccinations, particularly things like the flu and pneumonia vaccines, are safe, and that they actually can be particularly important for people who have any kind of disability, who may have more severe kind of infections. I guess the caveat is there's some sort of rarer kinds of vaccinations, like live vaccines used in like yellow fever vaccination, which may have more of a propensity to trigger immune response in adults. So while the general indication would be that yes, we would advise our patients to get any vaccines that required, we would say that in specific circumstances they should always consult with their own neurologist who knows their own sort of situation, to ask them for any unusual type of vaccine advice.
Mm-hmm. Yeah, it's good to remember that we can, and it is important to talk about the population level and in the context of vaccinations or anything else. But at the end of the day, especially after the disease process has started or has occurred, and you're looking at the rest of your life, and vaccinations, things are kind of a case-by-case basis, and it's important to, if you have any question, to talk to your neurologist about it to see if there's any concern or any precautions to take. So moving on to another question, kind of changing gears and pivoting, I'll direct this toward Dr. Murphy. There's a question that came in from a patient, a member of our community, with low vitamin B12 and magnesium. And there's a question about why would vitamins or any other nutrients be lower in cases of transverse myelitis? I don't know a lot about that, and just from my readings. So I would wonder, Dr. Murphy, if there is a connection between B12, magnesium, and transverse myelitis. If that work has been done, if there's any thought on that.
Mm-hmm. Well, I think definitely an interesting question. And I think what we are realizing more and more is these types of vitamins and minerals are commonly low in modern populations, where our diets may not contain all the required nutrients that we need. Also, we should remember that these types of vitamins and minerals aren't usually checked in people who are just walking around the street who haven't had any neurological problems. But we often, the moment that comes to check these kind of things is when somebody has had a neurological issue. And finding that a vitamin or mineral is low in that case, while it may be important, it doesn't necessarily mean that it has caused the problem. Um, we are particularly interested in vitamin B12, and we always check this in patients with TM or other spinal cord disorders because we do know that low vitamin B12 can exacerbate neurological problems. And we recommend that if patients with neurological issues have a low B12, it should be replaced. On the other hand, low magnesium is not known to have particular effects on the nervous system, and as far as I know, it doesn't have any known relationship to spinal cord disorders. But my general advice in the clinic is that if my patients are worried about their vitamin or mineral levels, they can take a standard multivitamin tablet available from a normal pharmacy, but to consult with their doctors before they decide to take any additional supplements, because there are vitamins that can actually be toxic to the nervous system at higher levels. And sometimes supplements can contain too much of these kind of vitamins.
Thank you very much for that. Dr. Wang, do you have anything to add, especially from the pediatric standpoint, if you see any different patterns in children?
No, I think that was a really good summary. I think it's a really important distinction about what is just because we test people, like Dr. Murphy said, and B12, we often will test. And then very low B12 can actually lead to a myelopathy, which I think she was alluding to, which is actually not inflammatory and in a different disease mechanism. So if the diagnosis should have actually been a myelopathy rather than myelitis, then it could be that the B12 itself could help with the treating the disease and symptoms. But in many cases, we have a bona fide transverse myelitis, and we just incidentally find these vitamin deficiencies. I think the one thing I would add is we definitely harp a lot on vitamin D levels being in at least a normal to slightly high range. And that is drawing a lot of inferences from the multiple sclerosis literature that has found associations with higher vitamin D levels, or sorry, maybe I should say the inverse, lower vitamin D levels and higher risk of developing multiple sclerosis. And in people already having the diagnosis, that lower levels tend to increase the risk of a relapse. So we generally recommend taking on top of a kind of a standard multivitamin and also an additional vitamin D supplement somewhere usually between the range of 1,000 to 5,000 units a day in order to supplement that vitamin D above a level of 50. Somewhere between 50 and 100 is where we like it. I think this advice may not be as relevant in transverse myelitis and ADEM and other diseases that are thought to be monophasic and very unlikely to happen again. But we're also learning there are multiple other benefits of improving vitamin D, and in our modern world, most people are just low on it. So there probably isn't a negative aspect of taking additional vitamin D if you are low.
Yes, and my understanding is specifically if you're looking at vitamin D supplementation to get vitamin D3 as opposed to D2, which can often be confusing when we just say vitamin D, vitamin D, vitamin D. Yeah. And so I just wanted to throw that out there, and maybe if you can say a little bit more about why the importance of vitamin D3 as opposed to D2.
No, I'm really glad you brought that up, Sam. I think that's very important. Oftentimes, a community provider may just see a low vitamin D and then supplement somebody on ergocalciferol or vitamin D2, which is the plant-derived form of vitamin D. And the typical dosing is something like 50,000 units per week. Which is really, easy for the patient, and it'll get the vitamin D level up. But we think that the animal-derived vitamin D3 or cholecalciferol has more potent immune regulation functions. So when we make that recommendation, we always will recommend vitamin D3, and that's just based on some past studies that suggest that the vitamin D3 interacts more potently with the receptor to regulate immune function.
That's good. Thank you for that clarification. I'm going to go back to Dr. Wang, continue talking to Dr. Wang. There's another question that came up from a mother whose son had a transverse myelitis a little over a year ago, last summer, and they were told at the time that he wouldn't be able to use his hands again, but they're now seeing movements in his hands. And so the question here is, could he or anybody in this kind of position benefit from any type of surgery? I'm thinking, would there be any potential benefit from some kind of orthopedic surgery, or I'm thinking potentially a nerve transplant, or under what circumstances you might think about going toward a nerve transplant. Dr. Wayne, could you speak some to this?
Sure. Yeah, I think we often get the question from our patients, what can I do next? Everybody knows that rehab and therapy is really important, but is there anything we can do to sort of, further encourage recovery? First of all, I just want to address that it's so often we get the story that an outside physician has told somebody that you only have till X, Y, or Z time to improve, and then you won't see anything, or you won't do this, you won't move your hands, or you won't walk. And it's so often that we see that this isn't the case. So for anybody who's been told that, please just take what some people say with a grain of salt. It may just be because they have a different experience with a different patient population, such as stroke, where the recovery can be very different. And really, there shouldn't be any sort of timestamp on your recovery. And a lot of it can be discouraging because then it's a self-fulfilling prophecy in that you won't continue to do therapy, and then you will just kind of be at a plateau. So I just want to first get that off my chest. And then in terms of the specific question, I think it really depends on the type of myelitis. For typical transverse myelitis, the nerve transplant is usually not a viable option just because of where in the nervous system the injury happened. You may have heard from some of Dr. Greenberg's talks in the past. He talks about kind of wire number 1, wire number 2. Transverse myelitis is typically the first wire from the brain down to the spinal cord. And then wire number 2 is a second nerve that comes out of the spinal cord and goes to the muscle. And the nerve transplant is specifically used for that second problem on the wire number 2. So for typically children who've had acute flaccid myelitis, the nerve transplant is definitely something that you should explore with your neurologist. And typically it works the best if it is done, I think, within a year of the diagnosis. There are some centers that will go past a year. I think St. Louis is one that has been coming up a lot as somebody, as a center that will transplant later. And that is basically taking a nerve that is more functional and using part of it to connect to the wire number 2 that wasn't functional or was damaged significantly during the myelitis. And then in more generalities, there's a lot of surgeries that can be done to assist and alleviate some of the complications of transverse myelitis. Scoliosis is something that we hear pretty commonly in the pediatric population. A child is growing, they may have some weakness as a result of transverse myelitis, particularly if it's higher up in the spine, such as the cervical upper thoracic, and that may be a surgery that helps with function after the initial event. Other things include orthopedic surgeries, like you mentioned, Sam, like tendon lengthenings. There may be things like botulinum injections, which aren't exactly surgery, but kind of serve as the same purpose, which is to kind of reduce the sequelae, the complications of transverse myelitis. And then I think one really interesting prospect that we're all very eager to kind of watch is what stem cells may hold in terms of restoring function. There is going to be a trial, I think, led by Dr. Greenberg and other people here at Southwestern, and taking stem cells that are bound to become nervous system cells, and then directly injecting that into the spinal cord of patients who've had transverse myelitis to see if that can help with remyelination. So I think that is not quite prime time, but it's something that I think people should continue to be on the watch out for, because it's certainly a type of therapy that we've never encountered and may have incredible potential in recovery.
Yeah, it's funny that you bring up the stem cell work that's going on. There's a question that came live asking to talk about stem cells and transverse myelitis. So that was a nice little tip there. And yeah, that's in some ways looking like kind of the next frontier in a lot of disorders, especially neurological disorders, to see if that can really work. It's looking at remyelination, looking at nerve repair even. There's a lot of unknowns, but there's a lot of work being done there. And then another question just came in live that might just help shed some light on the nervous system and recovery. Maybe Dr. Murphy, you can answer this, but when nerves get damaged, do they scar, or why can't they heal properly?
I think that's a great question, and we know some things about nerve regeneration after injury, but we probably don't have the full story, and that's again one of the mysteries of neurology. And probably a lot depends on the type of injury that the nerve has initially suffered, whether it was a damage to like the sheath or the lining of the nerve, the myelin, which does repair quite well with time in some patients, or whether it was a damage to the fibers of the nerve itself, the neuron, which can be more difficult to repair. But in either case, we know that there are things that patients can do to help this process of recovery, the most important of which is rehabilitation, physical therapy, and exercise. We know that this promotes nerve regeneration and improvement of clinical deficits. So our advice would be, at the moment, while we're still researching things like stem cells to help in the process of nerve regeneration or remyelination, in the meantime, the most important thing that our patients can do is to exercise those nerves and have a very good program of rehabilitation.
Thank you. It's very good. It's if you don't use it, you lose it, and so
exactly
that applies even to your nerves and your nervous system. So thank you for that explanation. And I'll direct this question to you as well, Dr. Murphy. There's a member of our community who asked, basically they have a TM and they have issues with also a bulging disc and pinched nerve in their lumbar spine. And they're going to have a microdiscectomy procedure in their lumbar region. And so I guess, is there really, do you see this commonly, I think, especially in older individuals with transverse myelitis and needing other kinds of spinal care that's more structural? And is there any concern with having this kind of procedure in context of the TM care?
Mm-hmm. Absolutely. Well, firstly, one thing to remember is that spinal issues are incredibly common, and that nearly all of us will experience some degeneration of the discs in our spine over time. So if we do an MRI scan of somebody's spine in their 60s, 70s, 80s, or even younger, we usually see some evidence of some degenerative changes with time. Now, some people can experience more symptoms related to those degenerative changes than others. So the first thing when getting evaluated for any sort of degenerative or structural problem of the spine is to see a good specialist, a neurologist or neurosurgeon, and to carefully go through your symptoms to try and determine if they are related to the degeneration or structural problems in the spinal cord, or whether they could be related to the previous issue of transverse myelitis. Secondly, in patients with transverse myelitis, a lot of patients may have some weakness or imbalance, particularly in their legs, and this can definitely exert more mechanical forces or abnormal forces on the lower spine in particular. So we do see that people who have some weakness or balance problems are more likely to experience back pain and perhaps these kind of problems than other people. So I think the final part of the question then was about whether it's appropriate to go on for intervention for such a problem, like for a microdiscectomy procedure. And the advice there would be that this is the type of thing that has to be individualized and reviewed on a case-by-case basis by your neurologist or neurosurgeon, or perhaps a combination of both, to see whether this kind of procedure may be helpful in a particular case, because a lot depends on the location of the disc, type of symptoms the person is having. But we have had patients with transverse myelitis who have gone on to experience structural problems of the spine and have had procedures such as this, with outcomes similar to that of patients without transverse myelitis. So I think the most important thing here is to have a very careful conversation with your physicians to make sure that this is the right choice for you, and to clarify what kind of things you can expect after the surgery. Often spinal surgery may alleviate pain, for example, but not necessarily improve things like weakness if that was more related to the transverse myelitis. So just to have a good idea of what kind of goals you can expect after the surgery.
Yes, thank you for that. I think it's just, there's not a ton out there, about, TM or other spinal cord disease plus spinal surgery. And it can be a little concerning, and what the outcomes could be and what the success is and who else has done this. So it's good to know that you can basically treat this kind of issue as a common issue amongst, all of us as we age, and go through the normal avenues and just be thoughtful and communicative with the neurosurgery team and your neurologist about your diagnosis of TM and kind of fleshing out what could expect to be affected. And then I want to get one more question in to Dr. Wang, a question that just came in live from the community, who's a mother whose daughter is just 7 weeks out from a TM diagnosis and having muscle spasticity in her upper legs. And is there, what treatment would you, could be used or is often used in lower limb spasticity, I think especially in children? Do you have anything to add to that?
Yeah, I think 7 weeks in the grand scheme of things is still fairly short, and I think that's where you really need a neurologist who can follow you closely to monitor progress that may come just from the natural healing process versus what needs to be treated because it's impairing things like ability to participate in therapy and so forth. So I would say typically we look at different classes of medications such as baclofen or various benzodiazepines to help reduce spasticity, which is essentially kind of increase in the tone of the muscle, kind of the opposite of being floppy, being difficult to stretch against the natural kind of tension of the muscle, and that can be certainly a big consequence of transverse myelitis. So medication management is where we often go, but I think that should be a discussion after other non-pharmacologic methods have also been explored. Just exercise on its own, stretching, participating in PT, those are very valuable ways to potentially reduce tone. And again, with somebody who is kind of fairly recently diagnosed, just keep in mind that as the recovery continues and mobility changes, there may be a need to continue to address whether medications can be, lowered, weaned, or if it's at a dose that's not helping enough, it needs to be increased. So I think typically those types of medications I mentioned, and usually a little bit further out than this, we'll start to think about things like botulinum toxin, which can kind of take away some of the tone. The benefit about things such as Botox injections is that it's more focused, and if there's only parts of the body that really have increased tone, whereas the rest of the body is fine, then that's a good way to really target that specific area of spasticity, and you get away from the systemic complications of those medications, which often are to make people feel drowsy or not quite like themselves.
Okay. Thank you for that, Dr. Wang. I think that's a thorough response to that question. So we're at the end of our hour, and I want to thank you both, Dr. Murphy and Dr. Wang, for your time today and for the discussion about your training and your work and your backgrounds. And we really, as a community, appreciate your interest in neuroimmune disorders and the work that you're doing, and are excited to see and hear about your future work in research and in clinical care. And thank you as well for your expertise in helping answer questions from the community. And thank you to the community, everyone who asked questions and who are listening today. Hope you all have a great week, and stay tuned for next month's podcast. Thanks again, all, and have a good day.
Great. Thanks a lot, Sam.